So, a warm welcome to the Kiel Imaging Seminar again. It's KIS Monday, and we're grateful to have you with us here. We have a fantastic speaker today. It's my absolute pleasure to introduce to you Professor Oliver Blanck. Oliver studied computer science with a focus on stereotactic radiotherapy treatment planning system, and he received his PhD for his preclinical work on stereotactic arrhythmia radioablation STAR in 2013 at the universities at Lübeck and Kiel. Since 2024, he habilitated in medical physics at the medical faculty here in Kiel. He is currently the research coordinator of multiple clinical trials on stereotactic radiotherapy in Germany. He's located at the Department of Radiation Oncology at the UKSH, which is the university hospital here. And he's the chief officer of operations and the head of medical physics at the Saphir Radiosurgery centers in Frankfurt and Kiel. As an active member, his work was awarded by several scientific societies and journals, and as a result, he's a member of the working groups for stereotactic radiotherapy of the German Society of Radiation Oncology and the German Society of Medical Physics. He is heading, for example, as a coordinator, some EU programs, Stop Storm consortium project and STAR. Before we start, to the audience, please wait with your questions until the end of the discussion. All right, Oliver, without much further ado, my monologue has come to an end, and the stage is yours.
Thank you, Jan, and welcome everyone to this lecture. I'm seeing a couple of well-known people in the room. So this was sent out, of course, also to the German medical physics community, and I'm very happy that a couple of colleagues of mine are also present in this talk. I'm not a professor yet, but I'm working quite heavily on that part. Thank you, Jan, again for the introduction. So I'll skip the introduction myself. I'm anxious to start and give a little overview over stereotactic radiotherapy, and especially on technological quality requirements and image integration for treatment and follow-up, which will be part of the core part of this talk, and then some radiotherapy systems for those who don't know them, and on image guidance, and to give you a summary. So first of all, the definition of stereotactic radiotherapy, so if you don't know that, is basically a method of percutaneous extracranial beam radiotherapy in which a clearly defined target volume is treated with high precision and accuracy with a biological high radiation dose, I'll come to that, in one or a few fractions with locally curative intent. This is what we have published a couple of years ago as a definition of stereotactic radiotherapy. And there's three forms, basically the classical stereotactic radiosurgery, intracranial single fraction treatment for brain tumors or vascular disorders, for example. And the fractionated stereotactic radiotherapy is 2 to 12 fractions for brain, and stereotactic body radiotherapy, SBRT, sometimes also known as Saphir, which we don't use actually in the nomenclature, is the extracranial treatment of benign tumors and functional disorders or malignant tumors throughout the body. We also published a technological quality requirements for stereotactic radiotherapy, and I'll come to that part in a bit. Just to give you an overview, so conventional radiotherapy, that's what we do there is hyperfractionated, so many fractions with homogeneous dose distribution. And here you see stereotactic radiotherapy basically is hypofractionated with inhomogeneous dose. That's kind of all the difference, bringing it to one sentence, with high biological radiation doses. And if you see the steep dose gradient here from the tumor to the rest of the tissue, for example, we need to have a very, very high precision due to the high doses that we're delivering. But how is actually treatment planning and treatment delivery done for stereotactic radiotherapy? So first of all, what we do is we do a treatment planning CT before we do basically the immobilization of the patient in some form. I'll come to that. And then in the treatment planning CT, we define the target that we want to treat for stereotactic radiotherapy, very precisely defined. And basically then we do treatment planning with our treatment planning systems. The dose needs to be somehow calculated and optimized for the target and the critical structures. And then we do some patient-specific quality assurance, basically. So we test all the treatments before treatment in phantoms or with measurement devices. Then we position the patient on the table in the treatment room when it's time. And we localize basically the patient and the tumor ideally. And then the dose will be delivered using linear accelerators. And there's a lot of issues that we have to address. And that's also why we published the quality requirements, which is coming from 3D imaging and image fusion. This will be one of the core topics today. Then the target definition also has some inaccuracy, the dose calculation, even the biological modeling, patient positioning, tumor localization, motion tracking, and the mechanical accuracy. And we want that to be ideally under 1 millimeter accuracy in the whole treatment chain, which seems, first of all, to be quite ambitious, but that's what we actually can do for many years now in clinical routine. And the core techniques for that is image integration, which is an integral part, image guidance, which is very important, of course, to see the patient and the tumor during treatment, and then also motion compensation, which I will cover in this talk. A little bit on radiation biology, just to give you an overview and not just have a deep look in this, but basically what we have is the linear quadratic model. Basically, when we have a specific cell range or cell line being hit by radiation, then we can, from cell lines, basically, and here's an overview over the different cell lines for very different tumor types and critical structures. We can estimate how much of the cells will survive after one radiation hit, basically, and we can scale that on the dose. Of course, if you use more dose, then less cells will survive than when you use normal dose. So basically, when we use 2 gray per fraction here in conventional radiotherapy, a lot of cells will actually survive, and when you use high doses, a lot of cells in these assays will basically will be killed from the radiation, from the single strand and double strand DNA breaks. But when we go to SBRT, so what you see here, the smaller part, the small line here, is when you hit the tumor with conventional 2 gray fractions over and over and over again, and you do this successively, basically over a couple of weeks, and then at the end, hopefully the tumor is gone. All the tumor cells are killed. And for SRT, for stereotactic radiotherapy, we use larger doses per fraction, and hopefully we can, for example, kill the whole tumor in 3 or less fractions, for example. And there's a couple of different things to consider for radiation biology. I don't want to go into much detail, but basically, fast dividing tumor cells are very radiation sensitive, and slow dividing cells, for example, prostate is very slow dividing and lung cancer is very fast dividing. Our slow dividing tumor cells are basically not so radiation sensitive in terms of the linear quadratic model. And this will actually, if you have like an alpha beta ratio, this is the ratio for the cell killing ratio. If that is low, you actually should hypofractionate, basically. So very limited fractions with high doses. And normally, if the tumors are fast dividing, normal conventional doses are very useful in this. So for prostate, actually, hypofractionation is very a must-do, basically, from the radiation biology perspective, but lung tumors are not. However, for lung tumors, we treat with stereotactic radiotherapy for decades now. And this comes from the problem that basically the dose that we deliver to the lung tumors is not enough in conventional radiotherapy. And we need higher doses, basically, higher biological doses over 100 gray, over 120 gray in biological dose. And normally in conventional dose, we treat tumors from 60 to 80 gray, which is not sufficient for tumor cell kill, basically. So that's what we do in stereotactic radiotherapy, high biological dose for fast dividing tumor cells, And from low dividing tumor cells, it's very beneficial to actually have this instead of conventional radiotherapy. But also dose, and this is super important for the talk, dose is not a single number. So basically, not just a dose is delivered to the tumor, but dose is delivered to a tumor in 3 dimensions, the minimum dose or the surrounding dose. Then we have a maximum dose, which is also looking here. If you look at the tumor control probability, the more dose you give, basically in the maximum, the higher your tumor control probability will be. And if you have the minimum the same, basically, and also the median dose to the actual tumor is also very important. And these 3 parameters are independent. So you can, of course, deliver homogeneous dose just at the minimum, or you can have very inhomogeneous dose with very high doses in the tumor center. And this is what we do in stereotactic radiotherapy throughout clinical practice. And again, like you need all 3 parameters, minimum dose, maximum dose, and the median dose to the tumor to have a very high local tumor control rate within the years. And here, just to give you an example, that's also from a physics perspective, very important. If you have a homogeneous dose distribution of like 10% dose inhomogeneity, you see this here, the dose is almost the same from the minimum to the maximum dose. This is a dose volume histogram here. And you see the dose drop off in 2 centimeters is basically here around 6 gray. And if you allow more dose in the tumor, you have a steeper drop off. You can see that here is almost 3 gray more drop off within a very short distance. And you have much more dose inside the tumor. So basically more dose inside the tumor, which is good, less dose outside the tumor because of steeper dose gradients, which is even better. But of course, if you have steep dose gradients, you want to have this precisely delivered to the tumor. And maybe you already get an idea that, yeah, where's the tumor? It's here in red, but you don't really see it on the CT images. So what we need is imaging, and this will be part of the talk here. So physics at its best, just to give you a short example and don't really look at all the details, but basically this group here in France, they looked at different doses. They delivered the dose to the surrounding tumor at the same level, 24 gray here, and allowed one group to have higher doses in the tumor itself and use this physical concept that I showed you. And they were able to show that the local tumor control is much better in an inhomogeneous dose group than in a homogeneous dose group. And they even had less side effects for the reasons that I've showed you. But again, we need to have this delivered very precisely. Otherwise, it doesn't really work. So on the indication itself, so what do we treat with this biology and physics aspects? Of course, we need to have this in the tumor board discussed. We treat in general small solid tumors if they're inoperable, recurrent, or even as a combination treatment. And this is what we do in our center here, mostly brain metastasis, so about 36% brain metastasis. Benign tumors we treat quite a lot, meningiomas and acoustic neuromas. We treat lung metastasis and primary lung tumor very, very often, liver metastasis and primary liver tumors. Bone and spine tumors, retreatments are often, and even prostate, which I said already from the radiation biology perspective, this is a very useful treatment, basically. Now, coming straight from that to actually what is required. What is required for stereotactic radiotherapy after we discussed what it actually is. And we have published this a couple of years ago, basically that one of the core aspects is the imaging for target volume definition. So the target volume and all organs at risk, the critical organs basically are defined using organ-specific imaging modality, and this is super important. And they need to be precisely and accurately registered to the treatment planning CT. Right? Everything is based on our treatment planning CT, but we don't see everything on the treatment planning CT. And here's a very simple example. Here, basically, you can guess already in the top part the tumor, but in the MRI, you see it a lot larger. Basically, the tumor is actually much larger than what you see here. And there's even a second tumor that we did not see on the other imaging. parameters, and in the lower part, there's even a very tiny metastasis that we did not see in the other imaging. So MRI imaging is essential to treatment planning for treatment for stereotactic radiotherapy. And we published also a guideline on how these MRI should be quality assurance. And this is very, very important because the dimension itself is important. The slice thickness and the pixel spacing is very, very important. You can see that here the tumors look very, very different if you have a below 1 millimeter resolution or 2 millimeter resolution. You get a lot of imaging artifacts, even from contrast. So the time when you do the contrast or the distortion, for example, if the distortion correction is not used correctly, then you have displacement. And you can already think about, if you don't use this distortion correction here, your displacement is almost half the tumor size, and you're basically missing your tumor completely with very high doses, and then you're basically treating more healthy brain than actual tumor. And of course, we want this to be super precise. The imaging needs to be as precise as the treatment delivery, and that's why we have published this quality requirements basically. Then the second part is patient positioning and target volume localization. We want daily in-room image guidance, which is very important. We need to understand where the patient is, where the tumor is ideally, or at least where surrogates are that are connected to the tumor. And this can be done with stereoscopic X-ray imaging or onboard CT, for example. I show a couple of examples later. And we want to have motion management and consistent consideration of periodic and non-periodic target motion. And then during the whole treatment process, from imaging, of course, if the patient breathes also during imaging, and the tumor moves during imaging, so you need to consider that. You need to consider that during target volume definition, during beam technique planning, so treatment optimization, dose simulation, target volume localization, and of course, dose application. And this needs to be time resolved. So you need to see this constantly and permanently, basically, when you treat the patient or you follow the patient through the whole process, you need to consider that consistently. And here's just a simple example of patients that can shift during the treatment, basically over time. You see here 4 millimeter shift, and I don't have to say much. If we want 1 millimeter precision and the patient shifts by 4 millimeter, of course, you need to capture that and correct that very accurately during the treatment. And also motion, if we have, for example, respiratory motion in the lung, we need to consistently capture that and correct it. The next part is collimation of the radiation and beam directions. And we want this, of course, also to be very precise. So generally 5 millimeters. Here, collimator, multi-leaf collimator or small cylindrical collimators needs to be used. We want the leaf width to be smaller than 10 millimeters for extracranial targets and smaller than 6.5 millimeters for intracranial targets to actually capture the very small, tiny tumors that we often treat. For example, brain metastases are 3-4 millimeter wide, and we, of course, need to make sure that the system can actually accommodate those tumors. And here, for example, also from many beam directions, not just one beam direction, but from different planes, non-coplanar beam directions is required to have a better dose distribution, for example, and also the dose calculation needs to be super accurate. We want a grid size of 1 to 2 millimeter according to the target lesion. Of course, in the brain, 1 millimeter, extracranial 2 millimeter might be okay. We want inhomogeneities in density inhomogeneities covered basically by those calculation algorithms that account for lateral electron transport. Don't want to go into detail there, but basically here you see a very tiny tumor in the ear canal. And this is a typical type A dose calculation algorithm. And if you calculate that correctly with a Monte Carlo calculation, you see here the dose is actually shifting into the bone here, into the ear bone. And the tumor is on the other side, not really fully covered by this. And of course, we need to have this accurately calculated and then used, of course, for treatment. The treatment unit itself, geometric accuracy of the system needs to be 1 millimeter for stereotactic radiosurgery and 1.5 millimeter for extracranial SBRT. And this needs to be verified by a system-specific end-to-end tests. That's what we do, of course, during commissioning of our systems, and routinely every month or even every day that we check these accuracies. And the dose accuracy needs to be within 3% in the target itself, measured with dosimetry systems that are useful for small field dosimetry. And here you see that also a patient with a lot of brain metastasis, and here you see very tiny tumors, very tiny brain metastasis, and larger brain metastasis. Of course, we want the same accuracy in the small ones as in the big ones. We want to have small field dosimetry for commissioning, because all the small fields needs to have the according detectors, of course, and we want specific end-to-end tests. So the whole treatment chain needs to be tested, both for static and moving targets. And this is also very important because this is not standardized yet. So we're working on that, but not yet fully standardized. So basically, if a tumor is moving and you treat that with some kind of motion compensation technique, we want that to be tested and accordingly check that the accuracy is correct. And of course, this needs to be regularly checked according to system-specific guidelines, and it needs to be day-to-day quality assurance needs to be done between the image guidance system and the treatment beam isocenter. This is also very important to check that your system is working properly every day that you're using it. We also put up some process quality requirements. Of course, standing operating procedures should be clear. We need to have interdisciplinary discussions in a tumor board. We need to have a trained professional, multi-professional team, of course, with radiation oncology, medical physics, and radiation therapists to implement stereotactic radiotherapy, and experience is required. We've shown that experience is correlated with treatment outcome in our groups already. And of course, the prescribing, recording, and reporting of those treatments needs to be in agreement with the international guidelines and standards, the ICU 91 standard, which is unfortunately not done in all the publications. And here's again, the reason I already said that dose is not a single number. This is very important. Dose is basically covering the tumor, the outer tumor part, and we have some hotspot in the hotspot dose in the tumor itself, and some median dose in the surrounding planning target volume and in the surrounding core of the tumor. And this needs to be all reported. And this is again also a very problematic in the literature still, that a lot of publications on stereotactic radiotherapy are not using the ICU 91 standards, and it's very difficult often when you read these publications that are basically not repeatable or not understandable of what was really done in terms of dose inhomogeneity, and which is, again, as I said, one of the core things for stereotactic radiotherapy. Now we come to the interesting part, is image integration. What do we need for imaging and for treatment, basically, inclusion and for follow-up? And this picture you already seen. So brain tumors are, of course, often only visible on MRI. There's a lot of work currently ongoing on contrast. There's a couple of publications recently on contrast media, basically different contrast agents, different sequences, the space sequence or standard T1 sequence, or the PEDIC basically sequence. So there's a lot of work ongoing right now with different sequences and contrast and so on, to understand better where we can see these tiny lesions and how we can really specifically and very precisely define the brain metastasis, as this treatment is used more and more often with all over basically clinical routine. But imaging also needs to accommodate for the high precision that we have. Here, for example, is trigeminal neuralgia that we very often treat. This is the trigeminal nerve here. And we use 60 gray in a single fraction. So for brain metastasis, we use 20 gray, for example. And here we use 60 gray, so very, very high dose on a very tiny spot. And of course, your imaging and image registration needs to be very, very accurate. And here you can see after treatment, for example, you can see the lesion that we have put up on this trigeminal nerve to reduce the trigeminal pain these patients have and not cause basically any kind of brainstem damage or other side effects. And you can already understand how precise this whole treatment has to be done. But we also have difficulties with non-standard 3D imaging. For example, here you see a coronary angiography from an AVM, a malformation, basically. And the problem is that these images are not really in the typical 3 planes, axial, sagittal, and coronal plane in a 3D data set that we can easily register to our treatment planning CT, but some form of video or projection images. And it's really difficult to integrate that into the modern treatment planning system still, even though those are used for decades. We, for example, use different MR sequences now to try to get the same information as the angiography data here, and you see it 3D years later fully obliterated after treatment. But again, like it would be great, and we're still working on this, to have these non-standard images basically also registered. And to give you another example, for example here, uveal melanomas, what we treat very often. You can not really see it on CT. You can often not see because they're very, very flat tumors on the in the back of the eye, basically here, and you can hardly see it on MR as well. So not even CT or MR will help you. And we even mark these tumors with small silicon markers before treatment to actually understand where the tumor specifically is. And in fundoscopy, you can actually see it quite nicely here. The tumor from the close to the optic nerve. But these images are projection images, basically camera images going through the lens. And to integrate these images into treatment planning is something we'll specifically work on. But what is still not solved, even though this treatment is done in over thousands of patients in Germany already. And of course, another point is the integration of functional imaging. For example, here, this great work that was recently published in Medical Physics. They're looking at functional images for example, motor cortex or something that we try to avoid with the radiation to basically spare the patient's functionality, but still treat the brain metastasis, for example, here with very, very high dose. And the integration of functional MRI has only been started in the past couple of years. So we are still very early on to integrate that in our treatment planning process, even though the information, the imaging is already there. On extracranial, so this was more intracranial. On extracranial treatment planning, we treat very often liver tumors, and here the registration is not so easy because normally the MR is done in inspiration breath hold, and we do, for example, our planning CT in expiration breath hold. And you see the tumor at the bottom part here near a little gold marker that we implanted is quite registered quite okay-ish. But the top, for example, here, this is a cystic lesion. It's not registered very well. I mean, you can see the difference quite clearly. And if we use that deformable image registration, you get much better registration. And this is also something that has only been released into clinical practice for the past 2 or 3 years. And there's not really a very good quality process installed for these kind of methodologies. And there's still a lot of work to do to have this used in standard routine practice with according quality assurance. For prostate SBRT, as I said, this will be part of the 3 guideline, hopefully this year, coming that prostate treatment in 5 fractions will become a new standard. But for that, we need MRI. We need to understand where the prostate gland is, maybe even where the tumor is in the prostate. However, we still treat the whole prostate. even though we have precise imaging, because we're not fully sure where the intraprostatic lesion is and if it's not more than just an intraprostatic lesion that you can see on MRI imaging. So here we have a clear need for better imaging, for better understanding. Basically, the urethra we can see, we can spare the urethra with high dose. We can treat the other parts of the prostate with higher doses, but we don't really fully know where the intraprostatic lesion is to treat just that. Right. I mean, the results of these trials have all been not super great so far. That's why we still treat the whole prostate. We try to treat, of course, the whole prostate with some kind of boost, so more dose where the intraprostatic lesion is. But really understanding fully where the tumor in the prostate is, to only treat that, that's something we should have a look at, and we're actually working with the with Jan here in Kiel on that part for the future. Of course, the integration of PET imaging is as important. We use PET imaging basically for all recurrent treatment or recurrences treatment. For example, here in the prostate, FDG PET, PSMA PET, basically, and then we treat only the lesion. But it's also very important for staging. So, for example, we published a work in our working group here. Initially looking at the institutional experience and technological advances. But what we found is that basically the overall survival in these primary lung tumor patients is better if we have PET staging before the treatment. The PET staging, no PET staging basically before treatment will result in a worse overall survival. And this is where we use PET the most, basically, for treatment planning. So lung SBRT and recurrences, that's what we currently do, and where we integrate these images. But also for response assessment, imaging is very important. Of course, here this is a tumor, brain metastasis that was treated with radiosurgery before, was stereotactic radiotherapy, and has a small recurrence 3 years after treatment. And then when we treated that with a high dose again, we see this very confused image, basically. Radiation necrosis is what we call that. But it first looks, of course, like this is massive tumor growth, and we need to distinguish that much better. And recently, the DEGRO has published some guidelines on that part to better diagnose and treat basically the radiation necrosis. In this case, unfortunately, the patient had to be operated, but there was no tumor left, only the radiation necrosis here. And also for lung tumors, this is very important, because when you use high dose, you create scar. And here, tumor in the upper left lung. This was actually our first treatment in Güstrow on the CyberKnife. And the first response is very good. The tumor is getting smaller. But then in the second response, and it was only 6 months later, you see this very confused, larger. If you compare the two here from this right after treatment, 2 months after treatment to September here. Of course, the radiologist would say, well, this is tumor growth again, right? But we used PET imaging then at that time, and the PET intake was about 3.8 SUV, is a bit borderline, could be recurrence, but we treated a very high dose, so we were very, very sure that there is no recurrences. And over time, we actually saw that the tumor, the scar here is manifesting itself. And then we saw during follow-up another interesting lesion here, which didn't really look quite as a new tumor, maybe some inflammation part. And we also did PET imaging, but you already see in this image here that the inflammation went smaller, and it was completely negative. But over time, the patient developed a new tumor. We actually had histology taken here to confirm it's a complete new tumor, and we were able to also stage this with PET. Accordingly, all the other lesions, like this one or the scar, were negative. And then Years later, it's still the two scars that we created from SBRT, and the patient in the end died at the age of 92, 12 years after treatment, with only those two treatments for his cancer, and he died of old age, basically on other causes. But what we can also use imaging for is precision analysis. For example, here we see a liver metastasis and a small metastasis that we treated with a higher dose in this case. And you see after 6 to 8 weeks, these liver reactions from lower doses, and the tumors are already smaller. But we can use this information to register this back to the treatment plan that we intended, and then we can basically in the patient see after treatment how precise the treatment actually was. And we were quite happy. We published this with a CyberKnife or with a conventional C-arm LINAC with ultrasound tracking. I'll show that in a couple of slides. But basically, we were able to show the accuracy of below 3 millimeter in these cases. And then over time, basically the tumor is more and more shrinking, and the liver reactions are consumed, and the liver is basically healing up again very nicely over time. So this is also what you can, of course, do and use for response assessment. But at the first time, of course, when you see this and you don't know about the high dose effects in the liver, of course, first of all, you think, oh, wow, the tumor is growing. But we need to differentiate here very clearly between tumor and reactions from the radiation. So image integration is key. But that's all what we do already in clinical practice. Something that we don't do in clinical practice that often is the treatment of ventricular tachycardia. Don't want to go too much into detail, but basically from a scar event like a heart attack in the left ventricle, you have slow conducting electrical channels that are causing a re-entry mechanism and causing the ventricular tachycardia. And normally you treat that with antiarrhythmics and catheter ablation. You need to implant a ICD generally for these patients because to prevent a sudden cardiac death. But here you can already see and understand maybe that it's really difficult to actually treat this with catheter ablation. So the RF here means radio frequency ablation energy, but the myocardium is very, very thick. And this channel that are causing the slow conducting channel that is causing this re-entry mechanism is basically very deeply situated in the muscle, in the cardiac ventricle, the myocardium. And you cannot reach that with this energy. And that's why we have about 20 to 50%, depending on what kind of energy you use and techniques, but at least 20 to 30%, we have recurrences if ventricular tachycardia after catheter ablation. And the option is very limited. And one of my core projects is basically the treatment of using stereotactic radiotherapy for this kind of disease. And here, again, the overview of how our treatment workflow works comes another layer of complexity, basically, that we try to integrate electrophysiology information, scar imaging, maybe so MRI and SPECT imaging, of course, that we already know how to integrate that into our processes. That's what we do daily. But basically the information, the electrical information to integrate that into the treatment planning process is not straightforward. And of course, we then have cardiac motion on top of respiratory motion, which makes it a lot more complicated. And here we have developed basically a couple of different mechanisms. We have integrated 2D, 3D registration. This is what we've done already for the AVMs, decades ago, basically with the angiography projection images, and you can register that to a 3D volume. We also integrated 3D imaging of these surfaces that we normally have from the electrophysiology. Basically, you go in with a catheter and you measure from inside the ventricle the electrical signals to define where basically your channel could be located. Or we even segment the ventricle into 17 segments based on the American Heart Association 17-segment model. And then we try to kind of come from the perspective of an ECG. You can read an ECG, a 12-lead ECG, and basically quite specifically define which of these segments is involved in the ventricular tachycardia. And then you can project that again over your treatment plan. And this is very complex. Even we don't fully understand it yet, how to integrate these images, but that's what we're working on right now. And image integration is a core component basically of the treatment of ventricular tachycardia, and functional information for treatment planning is very important. To just give you an idea what we can do with that, very briefly, we treated in our German Raventa trial 20 patients. We treated with 25 gray in the heart, so you really want to know where the location is. We had very good safety profiles, so only one grade 3 side effect. We had a lot of good responses here in these patients, so ventricular tachycardia events and shocks from the ICD before treatment, and many patients had no VT events after treatment. And even those who had, like this case, for example, was a very large scar. Patient was actually in induced coma. We treated a large part of the septum here in the center in Mannheim. And then 10 days after treatment, we were able to remap the patient, and you see a new trigger down here, which was then being ablated basically by another catheter ablation. But you see the original part where we treated the ventricular tachycardia is already very homogeneous. So there's no red means scar, right? And there seems to be a channel here going through, and this channel is gone, right? So after treatment. So very successful treatment, but of course, the image integration again is a key component to this treatment. And to report on this patient is now 4 years after treatment without any side effects and without VT anymore, and living a healthy life. So that is very impressive what we can do. But we need image integration, and we can show in our STOPSTORM consortium now more than 50 centers. We can already show from the clinical trials that have been published that about 60% of the patients have a reduction of 95% VT reduction. So we have almost complete remission in more than 60% of the patients, and in more than 90% of the patients we have at least a reduction of 50%. But there is still room for improvement, and we need to have better information of where the VT actually is to treat that. To go briefly over the radiotherapy systems that we use and the image guidance, and really just about pictures here. So for image guidance, we can use stereoscopic X-rays, we can use cone beam CT, MRI, and for motion detection, we can use all range of imaging, optical information, for example, surface scanners, magnetic tracking, ultrasound. So everything that you can think of has already been used in clinical routine, which is actually quite great. And then motion compensation itself. So if the tumor is moving, we can do a couple of things, for example, gating. So turn the beam on when the tumor is in the right position, or move the multi-leaf collimator with it, and have or robotic tracking and magnets. So everything that you can think of was already implemented. And here the Gamma Knife, one of the first systems, normally was in the 1968 already, with super high precision, 1 millimeter precision with that system, but with a frame. And the new systems, they have also imaging, for example, here cone beam CT, that we can understand where the patient is located and don't have to put the frame in anymore. The CyberKnife, what we have in Kiel and Frankfurt, we use stereoscopic X-ray images to register that to the treatment planning CT, and then steer the robot according to that position. Or here, modern linear accelerators from Electra and Varian, for example, with cone beam CT, with X-ray images, here ultrasound information, here surface scanner. So basically, all these systems have very highly dedicated image guidance systems available to locate and treat tumors very precisely. Where here, tomotherapy, for example, with an integrated CT information, can also now gate the beam with the Synchrony system that is normally used on a CyberKnife to do tracking, or for example, an MR-Linac system, so you have MRI during treatment and see basically the tumor all the time during treatment, which is really great. So from a problem issue, first of all, we have a temporal resolution problem from the motion capturing. So when you take an X-ray image, basically that's what we do still. But it's already out of date when you've taken an image, and of course, a continuous X-ray you don't want to do. That's why we normally use secondary information and correlation systems. But of course, if you have fast imaging, then normally it's not volumetric. Here, for example, a lung tumor that needs to be found in the X-ray images must be very fast, but it's not volumetric. So you only have the projection information. And of course, if you do a cone beam CT, you can't do cone beam CT all the time. From these patients, so that information is kind of missing. And what we use there is basically we correlate this internal information with external information, or for example, when you have an MRI linear accelerator, you can of course use that, or ultrasound. Or even transponder, when you implant little magnetic transponders that you can get location information out during treatment. That's also something we do quite often. And then what we do is we correlate the internal signal with the external signal, basically with different optical markers or surface scanners or whatever you can think of, basically. I don't want to go into detail due to time, and also look at relative position information. Here, for example, you can when you treat with the high dose beam, with a megavolt beam, you can already use that information at the back of the patient for imaging, or have the parallel imagers from what I've shown earlier on the linear accelerators. Basically, where you take the X-ray images, you can take the cone beam CT, you can take the projection images during treatment. So imaging during beam delivery is being considered, but again, like, this takes a lot of dose. Of course, it would be nicer to, for example, have something non-ionizing like transponder or MRI guidance here, for example. If the heart is beating for a cardiac application, for example, you can follow that information or that motion, basically, and you can adapt that treatment accordingly. And or ultrasound, for example, also we tested that quite a while back, and there are some applications in clinical routine where you can basically track, for example, some vessels or even the tumor itself in the liver, or for cardiac applications. And that information is, of course, very useful when you have that during treatment. I'm gonna skip that a bit. Here I already said that we do discrete imaging in general, and that we correlate that with some kind of external marker. That's quite what we do quite often if we don't have continuous information like from ultrasound or MRI. Here's my one example, basically, from very limited tumor motion to even cardiac motion that you can see here, to larger tumor motion, and all the way up to basically here almost 4 centimeters of tumor motion, which needs to be compensated. And this was, for example, a CyberKnife case where the robot is moving after that. And here a couple of systems. Basically, here is a gating system, what we use in Kiel, where you only turn the beam on in specific beam gating windows. For example, here you see that on the patient treatment. And every time the beam is in a specific breathing position, then you turn the beam on, and this is used in clinical routine more and more these days. Or you can use breathing coordinator, for example, that a patient breathes into a tube, and whenever the patient has basically is in breath hold. Here you can see that he's in deep inspiration, for example. Then the beam is turned on accordingly. And you can correlate that also with the cone beam CT to have really high precision images. I already said that at the beginning. We need constant motion compensation also during imaging, and you really want to have good images during treatment and not blurred images from the motion. And this can be done, for example, in deep inspiration. And then you can treat that. Treat the patient basically with this system, or you have if you have it, an MRI linear accelerator, for example. Here, very difficult location near the near colon structure or near the stomach. And then you can basically gate that during treatment here, for example, if the tumor is then on the right location with your MRI images, then you turn the beam on accordingly. Or here you see that, for example, even a cardiac application. So all the time, always if the tumor or the target is in the right position, you turn the beam on. And of course, this kind of image integration is very nice because you can actually see it during treatment and see it all the time, and don't have to use external signals or something like that. This is what we do on the CyberKnife here. For example, this is a correlation model that was built, for example, for a lung tumor that we can see, or here little gold markers in the liver. We cannot see the tumor in an MRI linac. You can see it, but with X-ray, for example, you don't. So you need to have little gold markers. Or here you can actually track the diaphragm. In this case, for example, for a liver tumor in the upper part of the liver, and this is then compensated for with the robot here, for example. Just to give you a short information here, basically here the patient breathes in and the robot moves with that motion accordingly to deliver that treatment very precisely. As I said, below 3 millimeter accuracy in clinical, so in the patient itself with 3 millimeter accuracy. The technical accuracy is actually below 1 millimeter if you treat a phantom, but of course patients are not behaving like phantoms and there's always some kind of error. But 3 millimeters in clinical in vivo accuracy is actually quite nice. Or here from one of my colleagues in Sydney, Paul Kiel, who's invented the MLC tracking. Very nice video here, for example, where he's using the beam images. So during treatment, actually, he's adapting the collimation of the beam according to the information that he's getting out of the images from the beam itself. So this is actually quite interesting. Since you have to beam the tumor anyway, you're using the information from that beam from imaging behind the patient. And then you're using that again to adapt your shape to the target, to the moving target as well. So this is really highly complex and has been implemented in the past years successfully for prostate, for liver, and for lung tumors already. So this is really nice work. In summary, and this is already coming to an end. In summary, in conventional radiotherapy, we have hyperfractionation, daily low homogeneous doses. In stereotactic radiotherapy, spatially targeted, image-guided, and motion-compensated inhomogeneous high-dose irradiation, generally in 1 to 5 sessions. The motivation is we have solid tumors, and we have maybe hypoxic cells, the tumor core. We have low alpha-beta ratio on the other hand, biological consideration. We need high doses to have double DNA strand breaks to actually kill the tumor completely, like in lung tumors. We have dose distribution. I think that was pretty obvious that I showed that if you allow more dose in the tumor, you can actually have steeper dose gradients and spare tissue better. For critical organs or even in all directions, what we need high accuracy in the whole body regardless of motion, and we need to have a focus team. I think that's one of the core things, and what we can do with it is treat primary selected tumors and functional disease, benign tumors, trigeminal neuralgia, lung, liver tumors, kidney tumors, prostate tumors, but also we can use it for palliation, for brain, lung, liver metastasis. We have very low risk of side effects. If we are precise enough to do this treatment, we can do this repeatable. We can even improve in oligometastasis. Didn't go into that today, but we can improve survival. We've shown that. And the high local control is associated with high precision treatments. We've already shown that for liver tumors in our working groups. And we can combine that. And if we combine that, imaging is even more important after ablation or after TACE, for example, arterial chemoembolization, for example, for liver tumors. That needs to be considered, and the integration of imaging is, of course, key, not only for cardiac arrhythmias, but for all treatments. As secondary imaging is absolutely essential, and the integration of imaging for treatment planning to specifically and precisely define what we want to treat and what we don't want to treat is absolutely essential. And with that, I thank you for listening to this lecture. Thank you.
Thank you so much, Oliver. That was very, very interesting. I'm not sure. Can you hear me?
Yeah.
Yeah, sorry, my microphone doesn't show, but great. Fantastic talk, great insights. I'm sure there's tons of questions from the audience. If you wouldn't mind posting them or raising your hand so I can invite you to ask your questions, so either post them in your chat or raise your hand for the questions. Let me start. So, I mean, I think this is a great example of where, in principle, we know what to do, right? But the technical implementation is just very difficult. We want to irradiate, right? But we know the target is moving. How do we follow the target? How do we define the target, right? First place. Which imaging modality do you use for that? And we know that many of the current imaging techniques are limited. So I was interesting to see as well that you found a larger tumor on the PET than on the MRI than on the PET, for example, which is supposed to be relatively specific or high sensitivity. So what would be a good measure in your opinion? I mean, in MRI, we usually see either changes in anatomy and in tissue density or something, tissue anatomy, or contrast agent, perfusion. But can you think of what would be a dream parameter to image?
Yeah, I mean that's a good point. I mean, what we do is, for example, for brain imaging, we use this treatment for more than 50 years already, right?
Mm-hmm.
So it's not really new. I mean, we're using it more and more because we think we understand more on the biology. We maybe even integrate targeted therapies and see more patients because the systemic problem is being addressed more accurately, better. And we can see smaller lesions, for example, and treat more. But what specifically we need for imaging, I mean, MRI, the standard contrast enhanced T1, is already pretty good and has been used for decades. The question is how relevant is a 2 millimeter brain metastasis, for example, also on the patient outcome. It is really difficult. I think our concept is more changing in imaging the patient more often. I think that is more important actually, and then having a specific image modality. I think for radiation necrosis in the end to differentiate, I think there's still a lot of things that we don't know and what we can learn and where we can do better imaging. But from the perspective of a clinical outcome, I think the highest impact has actually the frequency of the imaging and the integration of imaging into treatment planning to begin with, right? Standard radiotherapy normally doesn't use MRI imaging, for example, for whole brain radiotherapy. But if we have better images, we can tailor that treatment better to each patient. But we have to do it more often. So the demand is raising.
So you're saying that you need it more often to monitor the disease more closely.
Yeah.
To know when to apply the second or the next treatment. Okay, I can see
exactly.
that.
Yeah, I think that is more important than actual than the actual, down the detailed image parameter or imaging concept or whatever. I think there are just a couple of studies comparing space with T1 or T2. But, in the end, I think the highest impact has actually the imaging frequency.
I mean, all of those things only measure surrogate markers, right? And T1 and T2 and even diffusion, that's relatively macroscopic tissue properties.
Yeah.
Right. I was just wondering what would be if we don't want to measure a surrogate, what would be, right? Ideally, we would see where's the tumor DNA, sort of. I guess that would be the dream. Like where are all cells with that tumor DNA? But that's not there. But what could be, there's maybe some abnormal metabolism, as we discussed before, that which may show earlier than anatomical changes.
Yeah. Yeah, that would be important, for example, in the liver. I mean, for colorectal metastasis, we know that the MRI is always underestimating the actual tumor spread, the microscopic tumor spread. So when we correlate MRI to actually histopathological examinations, when they take out the liver metastasis, you always have like a 5 to 10 millimeter tumor cell spread around the metastasis that you see in the liver MRI. So of course, yeah, it would be. I mean, you're working on it, right? So this would be absolutely fantastic to be able to see where the microscopic tumor spread is, and to actually tailor the treatment better. Right now, we're using. For colorectal liver metastasis, we're using larger margins, for example. For brain metastasis, we're using a bit more contrast, a little bit more delayed, so that it's actually bigger, right? I have shown one of the images that we generally would tend to delineate more tissue than we might have to. But in the end, I think
metabolism.
Yeah.
I mean, one may argue that in the end, metabolism may not be a surrogate marker, but the correct marker, because like you could argue that every tumor cell has already a different metabolism. But then again, to be able to detect it, you need to have enough tumor cells to be above the detection threshold to detect the abnormal metabolism. But before I discuss on, isn't there any question from the audience? There is one from the chat. Yes. Timo Dam from Kiel University, SBMI. For which tumor and which patients do you see the biggest potential for improved or new imaging techniques or to actually improve survival or quality of life?
Yeah, this is indeed difficult. I mean, for brain metastasis, we treat for decades, so I don't think there's going to be much impact on clinical routine that we're not already using. Prostate is the same. I mean, we have very low toxicity. We have very high tumor control rates 10 years down the road with SBRT. On low risk and intermediate risk prostate tumors. On liver metastasis, I think there is still a gap of understanding which liver metastases have spread more to find the right patients, I think. But one thing is, of course, pancreas, right? I mean, this is the survival is very poor, especially if it's borderline resectable or inoperable. And understanding what we should treat there, especially if we should not just treat the lesion, the mass tumor that we see. I think there could be still some markers, some imaging where this could actually have an impact when we can tailor the radiation dose better to the actual tumor spread. In these diseases, because the life expectancy is very low to begin with, and we could probably do a lot more there. And we are utilizing SBRT in pancreatic cancer right now, but there's also a limited number of patients to
Yeah, I can see that. Anyone else? Any question? Taking a step back, radiation therapy is maybe another example An under-discussed general topic is like, what can we afford in terms of medical treatment? Imaging is expensive, radiation therapy is expensive. What are the benefits? And if you want to argue, what are the benefits per euro?
Yeah.
Now, my question doesn't want to start this ethical discussion, but my question is more with regard to the novel devices where you have, for example, MRI integrated into the
Yeah.
therapy device. That sounds great and fantastic. However, it's likely not either a very low cost device. Do you have a
Yeah,
comment on that?
yeah, I mean, quite a couple of people in this lecture, they know me, they know my standpoint on that. I mean, the MRI linear accelerators, they're super expensive. I mean, they're double the price than conventional radiotherapy systems, and you can already see quite well with CT. There's a new image modality or new imaging parameters that have been used and new techniques, for example, dual energy CTE or the called hypersight, from Varian. So there's a lot of good things that we can do with already X-ray images, which all the systems already have, right? So every system
Mm,
has some kind of X-ray, cone beam CT capability or whatever. And I personally think that this will probably be the mainstream going forward. Like MRI integration is great for certain applications, as I said, maybe pancreatic cancer, but on the other hand, we can already treat that quite sufficiently with the CT-based linear accelerators, or for example, with the CyberKnife implanting small gold markers with very limited risk to the patient. That's what we do in daily practice. And I think I have to implant probably millions of little gold particles before buying an MRI linac, right? So that in terms of cost ratio benefit,
mm,
of course, these systems are super expensive, and I'm not sure. I'm really, really not sure that we will see the cost ratio benefit in the future with these MRI integrated systems. I'm very skeptical. One company already went bankrupt, unfortunately. Very,
mm.
very, very unfortunately for us, because it's never good to have a new technology company going down, especially when they create really great systems. But as I said, the cost.
Right.
I'm running also a private practice. I wouldn't buy one of these systems in private practice because it's just not cost effective.
Yeah.
If you integrate it into university clinic with research on imaging, for example,
Yeah.
if you have functional imaging or something and integrate that into
Yeah.
research questions and so on, I think that makes sense, absolutely, and that's why these systems are in locations like Tübingen or Munich or Heidelberg. I think that's very important. But cost effective in private practice, for example, we use we are quite good with the CT based systems.
Mm. But then again, I mean, you showed as well examples where usually you want to have soft tissue contrast, and
Yeah,
although you named like photon counting CT and so on, CT is just not the great technology for soft tissue contrast. Well, you could
that's
do then
true.
like
That's
some
true.
tracking or to track the bones motion, and you assume you still know from co-registration where the
Yeah.
organs are, or the ones.
Yeah, maybe. I mean, we will see. We will see in the
Yeah,
future when we have the clinical evidence to see if
yeah,
we can really reduce the toxicity or increase or both
yeah,
increase the tumor
yeah,
control probability with these technologies
yeah.
or not. But
Who
we have
knows?
to prove it, and we have to prove it's worth it. And I think
Yeah,
we as a medical physics community also have to prove that the technology is actually worth the money that we're putting in. Otherwise, we're just raising costs without any benefit.
yeah, yeah. Sure, I agree. So, I don't see any other questions.
I think there's a
Would
hand.
you
I think there's a hand raised.
say it again?
Yep.
There are hands raised.
Yeah, hi.
Dana, please.
Yeah, my camera is not working, but you don't have to see me. So, oh God, it's working. Okay, so thank you very much for the talk. It was great as always. And I have a question, maybe a little bit off topic. I mean, stereotactic is, as you said, physics at its best, and it's beautiful and wonderful, but it's not something that you're doing every day. And especially if you want to start doing stereotactic, is there a comprehensive educational plan for medical physicists and also for physicians? Because you hear a lot of, yeah, I want to do stereotactic, but I'm not really, I don't have the experience, and I'm going to the DEGRO because there I will learn it, which is, well, it's nice, but it probably not really comprehensive as an educational plan.
Yeah.
Yeah.
I fully understand your question. So first of all, if you're not using it daily, then the question is why? Because we are treating about 20 to 25% of our cases are stereotactic right now. I mean, we have so many patients, we have to consider going down with the fractions. And for prostate, even for breast, is a bit debate, but for prostate, for sure, we're going down significantly with the fractions. For brain metastasis, we hardly do any whole brain anymore. We just do radiosurgery for most of the cases. Lung tumors, we're going down with the fractions. So I think overall it's very beneficial based on the outcome that we have and the clinical evidence that we see. So the question is why you're not doing more every day stereotactic radiotherapy. But of course, you need to start somewhere. And when you start, the most unfortunate thing is in Germany, we don't have the same as they have, for example, in the UK, where they have an accreditation program and lecturing system and so on, especially for SBRT or for stereotactic radiotherapy in general. We have a webinar series, and I think these are all recorded so far, I understand, from our working groups. So the DEGRO working group, stereotactic radiotherapy, and the DGMP, the medical physics working group on stereotactic radiotherapy. I'm in the board of both. So I'm pushing webinars on specific topics more and more often. And I think we did record that. So if you just shoot Christos Mousakis an email, for example, you should be able to gain some information. And there's good courses from Astro, from EFOMP, on stereotactic radiotherapy. There was a great course recently in Lisbon. I hosted a course last year from the EFOMP in Prague. And we have the yearly meeting, right? Our stereotactic radiotherapy meeting, which is Friday in Leipzig.
Yeah, I know the webinars, I have them all, and I've done
Great.
radiotherapy, so stereotactic. So the question, but I mean, I have colleagues that have not. And
Understood. Yeah.
I mean, I know, and Winterschule Pichel, of course.
Pichel. We have
Exactly.
a dedicated stereotactic radiotherapy program. Daniela actually Schmidt has integrated that in the Pichel Winterschule this year.
Yeah,
And my physicist is actually coming there too and giving lectures. So this is fantastic. So there is enough what we can do now outside the DEGRO and DGMP meetings, but also look at European level. No, don't just look in Germany. Look at the European level.
exactly.
Look at
Yeah, the problem is, I mean, and especially for the physicians often, is that, there isn't like a organized, or as you said, like in
curriculum.
UK,
Yeah.
that you have, from scratch. And I understand the problem, and yeah.
No, but I will take your remarks and bring it into the meeting on Friday and Saturday to actually steer it into the direction that we need a curriculum. We need a curriculum for stereotactic radiotherapy, and we don't have it at the moment in Germany. We have it on the European level. We have it on the UK level, for example. I'm always very excited about their progress, but we don't have it on the national German level, and I think we should integrate that. An
That's what I
accreditation
mean.
program, a training, an accreditation program, and a curriculum on stereotactic radiotherapy. I think that's super important.
Yeah, I think there is one from the Astro in Brussels this year.
There were actually many. So there was one in Lisbon right now. I think 1 month ago or something for 3 weeks. dedicated mostly to clinicians. So that there are courses, but you really have to look for them, and that's not. We should highlight them, and we should
Exactly.
distribute the information better. I think that we are not good at the information distribution on the curriculum and right now. I think we need to do a better job there.
Yeah, that's what I mean.
Yep.
Thank you very much. It's also always a pleasure.
Thank you.
All right. So I would like to thank you as well, all the audience. Thanks so much for joining us tonight, and especially Oliver. Great talk, great topic, great presentation. Thanks for being with us today.
Sure. Thank you.
All right. Thanks, everyone, and have a great evening, day, wherever you are. And see you for the next KIS seminar.